Good afternoon, everybody, and respected chairpersons. I'll be speaking on the topic evaluation of proximal femur plate and unstable proximal femur fractures. Pertochondric fractures are the most frequent fractures of the proximal femur and account for approximately 50% of all fractures in this region. Hegino et al. Reported that individuals above the 50 years of age have a lifetime risk of hip fractures, and that is 5.6% for men and 20% for women. The incidence of pertochondric fractures is also increasing among younger population because of increased road traffic accidents. No implant is universally fit for these fractures, and the best method for surgical fixation is still debatable. The PF plate, the PFLCB, was introduced in the 21st century as a new implant, which allows angular stable plating for the treatment of complex comminuted intertrochanteric, subtrochanteric, and osteoporotic fractures. The challenging goal in the management of pertochondric fractures is to achieve an anatomical reduction with a stable fracture fixation with low morbidity and early mobilization. The aims and objectives of my study was to determine the pattern and causes of trauma, the configuration of the fractures, the time for radiological union with this particular plate, the rate of complications with PFLCP, and the final outcome of fractures treated with this particular plate. This study was carried out on 20 patients having pertochondric fractures, all patients above 18 years of age with closed fractures, and patients below 18 years and having pathological fractures were excluded from this study. This is a prospective study aimed at evaluation of the role of PFLCP. The minimum follow-up period was 12 months. All the patients having unstable intertrochanteric and subtrochanteric fractures classified according to Evans classification and Sensheimer classification were included. The reduction was obtained before surgery under fluoroscopic view, and the PFLCP was put using minimally invasive approach in most of the cases. For more complex and comminuted fractures, open reduction was done using the plate as a reduction tool. And partial weight bearing was started at 6 weeks. Serial radiographs were taken every 4 weeks till radiographic signs of union were seen. In each follow-up, the patients were assessed clinically for hip or thigh pain, their walking ability, radiographic findings, neck shaft angle, hip joint congruency, and the implant status. And finally, the outcome was evaluated as per the Harris hip score. These are my observations. Most of the patients belong to 61 to 70 years of age group, and the mean average age of our study was 55.3 years. This is in contrast to higher age groups as reported by the Western literatures, but they are comparable to certain Indian studies. Most of the patients are males, that is 16 out of 20. Fall on ground was the commonest mode of injury, which included 10 patients, that is 50%, followed by road traffic accident, 8 patients, followed by fall from height, that is 2 patients. So according to fracture classification, the most common type was Evans type 5, that is 14 cases, that's quite a big number, 70%. And the least common were Evans type 3 and reverse oblique Evans and Sensheimer type 3B, having 1 case each. Most of the patients, that is 40% of the patients, 8 patients out of 20, they showed radiological union between 70 to 20 weeks, and the average time of union was 18.75 weeks. So we encountered a number of complications with this plate, which included, the most common of them are infection and non-union. The mean average operator time for in this study was around 123.68 minutes, and the mean average blood loss in a study was 476.32 ml. So finally, we calculated the outcome and got the result that 10 patients had excellent result according to Harris hip score, 3 had good results, 3 had fair, and 4 of them had poor results. The mean average Harris hip score in our study was 80.2, which was lesser than two other studies, which had 86.5 and 86.25 respectively. And one study by Lee et al., they had an average Harris hip score of 76.46, that is slightly lesser than us. So the final outcome was patients having more than 90 Harris hip score were graded as excellent, and there were 10 patients, 50%. 80 to 89 were graded as good, 3 patients. 70 to 79 graded as fair, 3 patients again, and less than 69 they were graded as poor, that is 4 patients. Stable fractures of the proximal femur can be treated with osteosynthesis with conventional implants, but management of unstable fractures is a challenge because of difficulty in obtaining the anatomical reduction and holding the reduction. So the importance of the lateral trochanteric wall in stabilizing the peritochondric fractures has been recognized by several authors. Several plate designs have been developed in the last decade for this. PFLCB using a MIPO technique has a high rate of fracture healing with the advantage of biological fixation. It is a simple and reliable fixation method, has a strong anti-rotation effect, there is no stripping of periosteum. So it can be used as a feasible alternative to other implants. But our study has one limitation, that it is a case series and not a comparison between two surgical techniques. So, but the data here analyzed pertains to a specific type of injury, that is all unstable fractures. These are certain cases. Case 1, a 26-year-old male had a road traffic accident, reverse oblique type intertrochanteric fracture with a subtrochanteric extension. This is a 13-month follow-up, and a patient has a good range of movement, treated with a PFLCP. Second case, 61-year-old male had a road traffic accident, events type 5 intertrochanteric fracture with subtrochanteric extension, quite an unstable fracture. Again treated with PFLCP, 12 months follow-up, again has a good range of movement. The third case, this was a failure according to, if I consider it as a failure. 70-year-old female patient, she had a fall at home in the bathroom. She had a type 5 Evans fracture. She was treated with, everything went well for a few months, but at 16 months follow-up, she started having varus collapse. And the plate started, the screws, the proximal portion of the plate started getting off. And she had a shortening of about 2.5 centimeter, which you can see in the image, and has an acceptable range of movement. She didn't go for any revision, she was fine with it. So to conclude my talk, it is the impression from a study that despite 3 different directions of PFLCP, it does not provide a rigid fixation, which ultimately increases the chances of developing a coxa vara and an implant failure. So this implant is good for achieving and catching reduced bone anatomical position, but it is not as rigid as other implants. And considering the time during surgery while fixing the plate and the amount of blood loss, which is more than the other extramedullary implants, this plate should be used for fixation only when there is no other possibility of fixation with any other implant. Thank you.